Hi everyone, welcome to today's overview lecture on transcranial ultrasonic stimulation. My name is Sjoerd Meijer, I'm a PhD student at the Donders Institute and I use ultrasonic neuromodulation in my research. So today we're gonna discuss a few topics. We'll start talking about what is TUS, and we'll talk about the bioeffects of TUS, we'll talk about the mechanisms, and we're also gonna discuss some of the applications for which it's used at the moment. So let's dive in. The principle. So just like you can focus light waves using a magnifying glass and deliver energy at a very focused location, we can do the same with acoustic waves. So here you can see an example of a subject going into an MR scanner, and they use a whole head cast model in which they focus ultrasound waves on a very specific location inside the subject's brain. Doing this, they actually use it for one of the applications of TUS, which is tissue ablation. So if you focus the waves on a specific location in the brain for a longer period of time, we can actually ablate the tissue, and it's heating up, and then over time there will be some degenerative effects. So other applications include drug delivery, so we can deliver drugs inside of the brain by opening the blood-brain barrier at a very specific location. And what we are most interested in is the application for neuromodulation. So we're not delivering that much energy for tissue ablation, but we actually give short, repetitive pushes against the neurons. So what you've seen just now were continuous applications. So the ultrasound energy was delivered continuously over time, and that will lead to a high level of thermal rise with respect to the mechanical effects. But what we can also do is use TUS to give short repetitive pushes. So we switch on and off the ultrasound waves, and this leads to delivery of mechanical energy and reduces the amount of thermal energy. So the mechanism through which we think it might lead to neuromodulation, or one of the mechanisms, is via acoustic radiation force. So by shortly delivering these pulses, you get a little push against these neurons, and that might change their functioning, leading to what we like to refer to as neuromodulation. And through a signaling cascade, which will be discussed further in the other lecture series, it might lead to the activation of mechanosensitive ion channels, and thereby lead to an increased influx of calcium and a change in the way these neurons are activated. So that's just an overview of one of the mechanisms. There are many more, but those will be covered in another lecture. So when we talk about non-invasive neuromodulation, so non-invasive meaning that we don't need to apply surgery to stimulate inside of the brain, what are our wishes? So first of all, what is nice about transcranial ultrasonic stimulation is that we can stimulate with a high focality. So by focusing all the waves at a similar location, we can reach a focality of just a few millimeters. We would like to reach anywhere in the brain. So most non-invasive neuromodulation applications today, like transcranial magnetic stimulation or transcranial electrical stimulation, are mostly focused on cortical regions. It's very difficult to reach those deeper brain regions that are implicated in many disorders. But with focused ultrasound, the promise is that we can actually target deep brain regions. We would like to have effects that are immediate. So we switch on the stimulation and we immediately see an effect on our outcome measure, rather than having to wait for a longer period to see whether there are any changes. However, if we could develop protocols that have longer lasting effects, plasticity-inducing protocols, those would be very, very good to have for clinical applications, where we could first stimulate for, let's say, 1 or 2 minutes, and then have longer lasting effects that might last, for example, during clinical interventions, that might boost the efficacy of those interventions. We would like the effects to be robust, meaning that across subjects, the effects will be relatively stable and in a similar direction. Having lots of variation might reduce the efficacy of using such a neuromodulation technique. We would like to see somewhat of a dose response. What does that mean? It means that with higher amounts of energy, we also see larger effects. So we can nicely tailor the amount of energy delivered with the effect that we would like to see. Maybe one of the most important things is that it's relevant for behavior. We don't just want to modulate what's happening in the brain, but that modulation should lead to change that is relevant to behavior. So if I use ultrasound, it should change some behavioral function. Of course, we also need it to be safe. It needs to be tolerable for a subject. It needs to be with minimal confounds. Confounds meaning, what can people hear from the stimulation? What can people feel? If there's too much going on, if the stimulation, for example, leads to a lot of prickling sensation, maybe even pain, that's something we would like to avoid, to have it applicable for many situations. And it needs to be feasible. We would like to be able to apply it, not just inside of our lab environment, but perhaps also be able to develop it in such a way that we can use it outside of the lab. So, ultrasonic neuromodulation in humans. It has been applied by lots of researchers across the brain. And as you can see from the many different studies, people are really thinking that this technique might have a future, especially for targeting deeper brain regions, involved in many of the cognitive functions that fall within the human domain. In our own lab, we are mostly focused on cognitive neuroscience, meaning that we use neuromodulation to study the causal role of certain brain regions in these cognitive functions. For example, looking into biasing of voluntary eye saccades by targeting the frontal eye fields, or trying to bias approach-avoid decisions when people are faced with a threat versus a reward, by targeting, for example, the amygdala and ventral striatum, knowing that many of these TUS targets have previously been shown to be involved. However, what we would like to be able to do is change their functioning just a bit and then see whether that might have an effect on behavior. We can look at valence and arousal processing by targeting, again, the amygdala, but also the thalamus, and perhaps also introducing our subjects into an MR scanner to see whether the changes in behavior are related to a change in neuroactivation of the target region. And in my own research, I use it to study about how people learn about threats, and particularly relevant perhaps for anxiety disorders. So going into those clinical applications, people have been studying the effects of transcranial focused ultrasound on Alzheimer's disease, generalized anxiety disorder, and drug-resistant epilepsy, knowing that if we could modulate the brain regions involved, we might be able to reduce the burden and improve the functioning of these people. If you're interested in looking into the clinical applications and what TUS is used for today, you could, for example, look into the NIH report. You can, for example, search on ultrasound neuromodulation, and you'll see some of the studies that have been awarded money to do these kind of investigations. So going a bit more into practice. When we target, we often use something called neuronavigation, because if we just put the stimulator anywhere, we don't know exactly which brain region we are targeting. In particular, for a brain stimulation technique in which we can have a millimeter precision, we need to be very accurate. And that is why we often acquire a brain scan of our subject before we start stimulating. And within a brain scan, we find the right target location, we pinpoint the target location, and then we find a location outside of the head in which we can most easily reach our target. And then we can use neuronavigation to actually find exactly on the scalp where we need to be for that particular person. Because for anyone, it might be in a slightly different location. So how do we know how much energy is delivered at the target? What you should keep in mind is that we need the acoustic waves to travel not just through the skin or scalp, but also through the skull. And the skull is the biggest boundary for delivering the energy at our target. So how do we know how much the target is exposed to the energy for each individual subject? Because what we also know is that skulls can be highly variable. So from one person to the next, these skulls might look a lot different in terms of thickness, in terms of their morphology, how much cortical and trabecular bone, and these all have an impact on how much energy is delivered and how accurate we can target. So we would like to estimate some variation across subjects. One of the ways in which we can do this is using structural MRI before we have our stimulation session. We acquire more standard anatomical or structural scans like a T1 and T2 weighted image, in which we can segment cortical, white matter and CSF. But we are also having recent developments in which we use ultra-short echo time imaging, in which we can actually get a better image of the skull. And that is very important, knowing that how much of an impact it can have on how much the target is exposed to the energy. So what we often do in our lab is we segment these images and we look at the skull, we look at the white matter, gray matter, knowing that in particular the skull has the most impact on target exposure. And then we try to create such an MR-based skull. You might wonder, why not use a CT image for this? Well, actually people are exposed to energy which might be harmful along the ways. If you do it a lot of times in healthy subjects, most people would prefer not to do that. So we try to use a way in which it's completely safe for our subjects. And we run two types of simulations. We run an acoustic simulation, basically getting an individualized estimate of the energy distribution, in particular at our target site. And we also run a thermal simulation, knowing that depending on the stimulation protocol that we use, there might be some increase in temperature. So this temperature rise is something that we, when we are most interested in mechanical effects, like to keep as minimal as we can, because there's also something called thermal neuromodulation, which might happen by the brain even just increasing in 1 degree Celsius. So having run these simulations, we can get an estimate of how much energy is delivered at the target, but also whether it's safe to use across subjects. Here are a few examples of subject-specific simulations that were run in our lab. And I would like to highlight that the location is relatively similar. So we can target quite accurately at the same location, but there might be quite a big difference in intensity that is delivered at the target site. And getting some idea of that variability might be able to tailor the protocols for specific subjects, making sure that the energy delivery is similar across. So we've run these simulations, but these are still very much estimates. And it would be interesting to see if we can actually image how much energy is delivered. What we can do is we run these acoustic simulations. Here's an example from another study. And if you put this subject into an MR scanner, and we use a protocol which is called MR acoustic radiation force imaging, with which we can image that little push that we think leads to neuromodulation, we can actually see that on the top row, that the simulated estimate is really quite similar, especially in terms of location, with what is recorded with the MR scan. This can be a further confirmation of our simulations being accurate. Similarly, we can do this thermal imaging. So we have a thermal simulation on the left, and then we can see whether the thermal rise that we can estimate in the top row in the simulated bar, whether it's similar to the experimental temperature rise that we measure with MR. So we know approximately how much energy is delivered, but what might be even more important is what is the effect on neural activation? How much of a change is there? And is it relatively stable across subjects? So we would like is an idea of the target engagement. So how the target responds and how that leads to a change in behavior. And here I'm talking about both online and offline target engagement. Online meaning the effect on your outcome measure during stimulation, whereas offline protocols refer to stimulation with a protocol that might lead to longer term effects and then over the time measuring effects on your outcome measure. So one way in which we can do this, and also a way in which we do this in the lab, is by combining brain stimulation techniques. So TMS, transcranial magnetic stimulation, is an established method in which we could stimulate, for example, the motor cortex. And by activating the motor cortex, you might get a little twitch of your hand. And we can very nicely read this out. It's quite stable for each stimulation. And then by combining this with TUS, we can actually look at the impact. Does TUS lead to more excitation, so bigger twitches? Or does it rather inhibit that area, so we would see a smaller twitch? This is called, the switch is often recorded and talked about it as a motor evoked potential. You will hear this in the other lectures as well. So here, some of my colleagues looked into combining TMS with TUS. And on the y-axis, you can see the MEP amplitude. And on the x-axis, you can see how that MEP might change comparing baseline versus using TUS. And what you can see is that the MEP is reduced. So the interpretation here would be that TUS leads to an inhibitory effect on the region of interest. And this is for online TUS. In other labs, they've also used offline TUS protocols, in which they stimulate the motor cortex for a longer period of time, and then over time use TMS as an outread of how the excitability has changed. And here you can actually see an excitatory effect of TUS. Keep in mind that the effect of TUS does not just depend on the protocol that you use, but even more so on the state of the brain. So what in some situations might be an excitatory protocol, might in other situations be an inhibitory protocol. So keep this in mind when you design your own study and choose a certain stimulation protocol. Can we image target engagement? So we use a brain stimulation technique and we combine that and we find an effect on our outcome measure. What we would like to know is that intermediate step. Is TUS leading to a change in brain activation that then leads to a change in our outcome measure? And actually we can use imaging methods to look at this. So we talked about changes in excitability, and one of the ways in which we can measure changes in excitability in the brain is using magnetic resonance spectroscopy. And basically from a small voxel or a small little box inside of the brain, we can measure the GABA and glutamate, which are neurotransmitters important for the excitability of that brain region. And we can see whether it changed after applying TUS. And this has actually already been studied in humans. And what you can see is when you stimulate TUS at the posterior cingulate cortex, that actually there's a reduction in the ratio between GABA and water. And that means that it's very specific to the stimulation side, these effects. And then there's another way to image target engagement, which is using functional MRI, in which we can look at changes in bolt activation. For example, here in non-human primates, they stimulated the amygdala. And they used an offline protocol. Remember, you stimulate for a period of time and then you would expect some plasticity induction, which leads to longer term effects or offline effects. So here they stimulated for 40 seconds and looked at the effects of brain activation. And what they actually observed is that for the specific brain region that they targeted, they saw that its coupling profile with the rest of the network changed. And it didn't change for other brain regions, meaning that the effects of TUS were specific for the targeted region. Again, showing target engagement. In our own lab, we also use resting state fMRI to image target engagement. And that means that the subject is laying inside of an MR scanner. They just relax and they look at a little fixation cross on a screen. And before they go into the MR scanner, we stimulate with an offline protocol. And what we would expect to see is, again, this very specific change in the coupling profile for the region that we target. But keep in mind that the effect of TUS protocol might be very much dependent on the state, on the brain state. So that's why we're also thinking about introducing task fMRI, in which these brain regions play an active role, and this might change the effects that we could observe. Moving on to target specificity, we've talked about it just a little bit. Again, in a situation where you might combine TMS with TUS. So we target a specific brain region in which we're interested, such as the primary motor cortex. And we look at changes in excitability. But keep in mind that subjects might perceive the stimulation, and these might also affect our outcome measures, which are indirect effects rather than the direct effects in which we're interested. So what we could do, for example, is use an active control site. So we stimulate a brain area which we don't think is involved in the outcome measure, and still people have a similar perception, they're being stimulated, they might hear similar things, they might feel similar things going on, and then still we would like to see that the effects are not there, but very specific to our region of interest. And then there's a condition called sham, in which you basically do nothing, and it gives you an idea of how the system functions during baseline. And what my colleagues looked at, here again, the same slide where they show a reduction in motor-evoked potentials for TUS when you target the primary motor cortex. But when you compare it to stimulating an alternative brain region, or just playing a sound, which is very similar to what people can hear when you stimulate with ultrasound, you see very similar effects. Again, showing how important it is to think about your research design and the perception of subjects during your study. Because we could have inferred that TUS leads to a reduction of MEP, so an inhibitory effect. But if these other conditions give the same effect, we really need to think about what that means and how we design our studies to be able to disentangle these direct and indirect effects of TUS. Coming to the end of my presentation, I would like to highlight the International Transcranial Ultrasonic Stimulation Safety and Standards group. And this is basically, ITRUS is an international consortium, and they are developing guidelines for how to design your study, how to apply TUS safely in humans, and I would very much advise you to just have a look at their website if you're planning to use transcranial ultrasonic stimulation in your own studies. I would like to thank you and my other lab members with which we try to work together on transcranial ultrasonic stimulation. Thank you so much.